My name is Jason Banks and I'm a neurosurgeon at the Spine and Neuro Center here in Huntsville, Alabama. And I'm here to discuss cervical spine conditions and treatments, both surgical and non-surgical. With this presentation today, you should be able to receive 1 hour of CME and CEU credit through Huntsville Hospital and Corporate University. So the objectives that we have today include cervical spine normal anatomy, presenting signs and symptoms of neck pain and neck issues. We'll also look at conditions, the evaluation and diagnosis of these conditions, and explore both non-surgical and minimally invasive surgical techniques, such as a common operation such as an anterior cervical discectomy and fusion, and other new technologies that have recently come about to aid in this fusion. The cervical spine consists of the axial spine, which includes the C1 and C2 vertebral bodies, and that's where most of your rotation comes about, as well as the subaxial spine, which is considered the cervical vertebra C3 through C7. This would bring about 7 cervical vertebrae from C1 to C7. That is what we call the cervical spine. Different parts of anatomy that we can see. You have the C1, C2 junction, as we discussed before. That's where the majority of the rotation comes in. That's where the dens and the atlas come together for most of your rotation, as well as your flexion and extension here. And then the subaxial spine from C3 down to C7 is where most of your flexion and extension occurs, and the rotation is less obvious and less used at those areas. Things that are important when evaluating a cervical spine x-ray include the anterior vertebral body line, the posterior vertebral body line, and the interspinous line to determine whether or not there's a subluxation or an offset that would be indicative of a cervical spine injury or a degenerative change. This here is a cervical vertebra from a top view and a side view, and how you can recognize this as a cervical spine vertebra is the foramen transversarium, where the vertebral artery passes. You can also see the lamina, the spinous process, the vertebral bodies, and the articulating facet joints where the motion occurs. As far as the disc anatomy that we see, it's a cushion composed of the nucleus pulposus, as well as the more firm annulus fibrosus that sort of is like the radial tire. The vertebral bodies sit on the vertebral discs that provide the cushions there. And the job of the intervertebral discs is for a shock absorber in both the cervical and lumbar spine regions. Patients who come to see both primary care physicians as well as neurosurgeons complain of neck pain very often. They can also have this neck pain either independently or associated with other signs and symptoms such as radiation to the arm. It could involve numbness and tingling in different dermatomal distributions. They can also present with headaches, upper extremity weakness, and even subscapular shoulder or upper thoracic spine pain. After a physical examination and a history is taken from the patient, we oftentimes send this patient for x-rays, oftentimes an MRI scan or a CT scan, and a more invasive procedure that's an older technology that's still utilized very frequently is a myelogram with a post-myelogram CT. Here's a picture of the cervical dermatomes that you can see where the distribution of the nerve roots shows the sensory exam findings, especially in the arm. And you can see that the upper portion of the cervical nerves involve the shoulders and the cape region, and the lower down cervical vertebra and nerves involve the arms before they go back into the thoracic region at the nipple line usually and start to involve the thoracic dermatomes. This here is another depiction, as you can see, of the cervical spine region in green here, and the thoracic region begins in blue. The natural history of cervical spine disease is that 40 to 60% of patients will resolve symptoms without any sort of surgery whatsoever. Oftentimes these patients don't even require a visit to the doctor's office and may not even come see their primary or family physician. And obviously those patients do improve without any sort of treatment whatsoever. About 20 to 30% of these patients will have this flare-up off and on, and oftentimes by the time they come to see you or I, they continue to have these flare-ups that they like to have addressed. only a small subset of patients that we see actually require surgical intervention. Different types of conditions that we treat and are very successful at having improvement with include cervical disc herniations. A very common term that's seen throughout is and discussed in both lay language as well as medical literature is degenerative disc disease. Other conditions that we treat include cervical spinal stenosis, cervical spondylitic disease, and neck strains, and we'll get into better detail about what we're discussing here. The discs, as we talked about, are soft, and here's another depiction of that. The nucleus pulposus is the soft, spongy portion of the disc, and the annulus fibrosus is the more firm, band-like structure that retains the nucleus. The different descriptions that we hear and see in MRI and CT reports include disc degeneration, prolapse, extrusion, and sequestration, and how those are all addressed are different depending on what we actually find on our MRI scans and intraoperatively. A herniated disc is a very common condition that we see. It's usually related to a piece of cervical spine disc that is ruptured out against either the spinal cord or the nerve roots, and is successfully treated with operative therapy by removing that disc herniation. Symptoms of the herniated disc include pain down the arm and a dermatomal distribution, as you have seen before. It usually follows the location of the nerve roots, and where their sensory nerves extend into the arm can often cause weakness in that distribution and also can give you intense pain. Oftentimes, subscapular pain or upper thoracic pain can be associated with herniated discs in addition to the pain down the arm. A radiculopathy is a description of what we associate with nerve root pain, and that can be pain that radiates from the neck and shoulder in a radicular distribution, as discussed before, as seen in the dermatomal slides as you saw earlier. This arm pain usually is much worse than the shoulder and neck pain that they have. A condition called myelopathy is related to cervical spinal cord compression, which can include signs and symptoms of clumsiness, hyperreflexia, oftentimes bowel and bladder dysfunction, gait difficulties, spastic gait, and sometimes you can see a cervical sensory level such as you would see in a cervical spinal cord injury. Myelopathy is also another term that you may remember as an upper motor neuron sign. Cervical spondylitic disease, in my mind, is a condition that is a description of what we see as an age-related degenerative change in the cervical spine associated with wear and tear and aging. It's also known as cervical osteoarthritis, can also be considered another way to say degenerative disc disease. This occurs when you see microinstability in the cervical spine, where bone spurs begin to form at areas between the vertebral discs as a healing mechanism to try to obtain stability at that level. And as the cervical spine tries to stabilize itself, bone spurs and osteophytes begin to form. As long as these bone spurs and osteophytes form in the vertebral bodies and across the discs and do not involve the neuroforamen or the cervical spinal cord canal, then oftentimes these osteophytes are asymptomatic and do not need to be treated. They're very commonly seen on x-rays, and just because you see these x-ray findings does not mean that that patient is symptomatic from what you see on x-ray. When they do become involved with cervical spinal cord compression or nerve root compression, then signs and symptoms similar to what you see with herniated discs can be seen, such as arm pain, weakness, loss of reflexes, or sensory changes. This slide, as you see in front of you, shows cervical disc degeneration and how an osteophyte forms. If it forms anteriorly, then it obviously does not press on any neural structures and essentially does not need to be addressed with an operation. There are some instances where a very far anterior disc osteophyte complex can become so large that you can have dysphagia or swallowing troubles from this. Cervical spondylitic disease with myelopathy involves upper motor neuron symptoms with clumsiness, sensory changes, and hyperreflexia, as we've seen before. These bone spurs and irregularities can become large enough to compress the cervical spinal cord and cause symptomatology. Oftentimes, patients with cervical radiculopathy and cervical myelopathy can have permanent disability if it's not treated in a timely fashion. And oftentimes, a patient with cervical myelopathy that's untreated, the natural history is for that person to become permanently incapacitated without ever having room for improvement. Sometimes patients would lose permanent nerve function with a fall or a trauma, such as a motor vehicle crash. Cervical stenosis is a degenerative condition. It's also a radiographic description of a decrease in the size of the spinal canal. Oftentimes, cervical stenosis can be diagnosed on an MRI scan, but can be completely asymptomatic. It's very typically present in patients that are over 50 years of age and becomes more common as patients age. The slide here shows a picture of a normal cervical spinal canal. Also, next to this shows an area of cervical stenosis. As you can see, the cervical spinal cord becomes severely compressed and becomes symptomatic at this point if the cervical spinal canal diameter is decreased substantially. This can be treated with multiple different types of surgical interventions, as we'll discuss later. Muscle strains are very commonly diagnosed by neurosurgeons as well as primary care physicians. It can involve the feeling of tightness in the muscles and soreness in the back of the neck. It can cause muscle spasms, but oftentimes does not show any neurologic deficit or symptom or sign associated with a radicular pain or pain down the arm. Oftentimes, physical therapy treatments and exercise, chiropractic treatments, anti-inflammatory medications, and muscle relaxants can be successful in helping these patients improve. Some of these non-surgical treatments include physical therapy, medications such as anti-inflammatory medicines. Physical therapists and chiropractors can utilize ultrasound, electrical stimulation, heat or ice therapy that may be tried at home before patients come to see their physician, and even deep tissue or gentle massage and stretching. Physical therapy and spine pain as well as chiropractic treatment can be very successful in treating short-term neck pain and long-term prevention of problems later on. There's some typical exercises that are good for maintaining posture that we like to instruct patients to do. Most of these include making sure that someone's neck and shoulders line up with good sagittal balance. Oftentimes as patients age and they develop cervical spondylitic changes that you can see an older person's head is more forward on their shoulders and they kind of walk in a humpback type position. And these patients, as we age, oftentimes see their lack of rotation, especially if they think about driving a car and trying to look behind them and make a turn. Their neck doesn't turn as far as it used to a few years ago. That's indicative and a good description of what someone who develops cervical spondylitic disease or age-related degenerative changes experiences clinically. Spinal decompression therapy is something that's been commonly advertised on TV and newspapers and magazines that is actually, in my mind, a treatment of cervical spine disease that's been utilized in the past. It can be used to primarily treat disc injuries to the neck and low back and also release pressure on the spinal nerves. It's a non-invasive technique that can treat common conditions with pain down the leg that is often called sciatica. Can also reduce symptomatology related to bulging and herniated discs, as we've discussed before. This can also cause relief of pinched nerves in the cervical spine by reducing the amount of pressure on these nerves and hopefully relieve the radicular complaints that a patient may have. Spinal decompression is an FDA-cleared procedure using FDA-cleared equipment that produces a vacuum effect known as negative intradiscal pressure that can hopefully allow disc material and pressure against the nerves to be pulled back away from these nerves to reduce their symptoms. Common treatments that we perform surgically include an anterior cervical discectomy infusion, which is quite often performed for radicular pain and pain down the arm, as well as for severe cervical stenosis and cervical myelopathy. A posterior discectomy, a laminectomy, or a laminoplasty would be a way to treat a patient in the posterior region or back of the neck. And then a cervical corpectomy and a fusion is another way of treating for cervical myelopathy and or radicular pain through an anterior approach or front portion of the neck. And in conjunction with anterior cervical surgeries, there's also newer technology with a disc replacement. And newer technologies that are out include cervical stimulators. An anterior cervical discectomy and fusion is one of the most common operations performed by neurosurgeons. It also has about a 90% success rate most of the time. With this procedure, the intervertebral disc is removed, and this would allow access to both the spinal cord and nerve roots at the level of being treated. The pressure of the nerve root is relieved by removing the disc fragment or bone spurs away from the cervical spinal cord or nerve roots. At this point, a bone graft or a plastic PEEK graft can be placed between the vertebral bodies to allow for the maintaining of the vertebral body height between the discs and open up the nerve foramen with this procedure. After the bone graft is in place, most neurosurgeons utilize an anterior cervical plate. This is an X-ray of an anterior cervical discectomy and fusion. As you can see, there is an anterior cervical plate, which is the metal structure with the two screws that you see on lateral views, with the bone graft between the two vertebral bodies where the cervical fusion has occurred. What you're about to see now is a video animation of how an anterior cervical discectomy and fusion is performed. It's often performed with a small transverse incision over the lateral portion of the neck. This allows access to the intervertebral disc, as you can see, being removed here. During this procedure, the entire disc is removed to allow access to the nerve root, as you can see it becoming decompressed by removal of the disc fragment herniated against the nerve root. After the disc is removed, a bone graft or plastic PEEK implant can be implanted, and then here's the plating apparatus with the screws that are attached. After this procedure is done, most neurosurgeons do not require long-term use of a cervical collar with the addition of this plate. The plate is, and bone grafts are to be in for the rest of the patient's life unless they require an adjacent level treatment that would require removal of this plate and replacement at a different level. An anterior cervical discectomy and fusion is to treat, more importantly, arm pain, oftentimes intractable neck pain, although the success of treating neck pain alone with an anterior cervical fusion is less likely. It is also to preserve or enhance neurological function, such as a patient with a radiculopathy with weakness of their biceps or triceps, or with cervical myelopathy with cervical spinal cord compression. It can also provide cervical stability and treatment to prevent newer formation of osteophytes at a later time. An example of a patient that we would see for surgical intervention may be a 44-year-old female who works as an office manager with the diagnosis of cervical spondylitic disease on her MRI scan and a noted degeneration at the C6-7 region with bony osteophytes present. As you can see on this X-ray, there are some anterior bony osteophytes as well as posterior bony osteophytes and loss of disc space height at the region of interest at the C6 and C7 vertebral body levels. Her MRI scan does show a herniated disc at the C6 and C7 region in both an axial and a sagittal plane. She would present with neck and arm pain, and the cervical surgery would allow the arm pain to resolve and treat this by removal of the disc away from the nerve. It would help her pain improve and also preserve her neurologic function and improve her weakness. It would also provide this level stability to prevent a recurrent disc herniation at a later time. In my practice and most other neurosurgeons, bone grafts for the disc space fusion can include allograft or donor bone from a cadaver. They can also be autograft bone from a patient's hip, although that's less commonly used these days. Newer treatments include a polyether ether ketone spacer, a plastic spacer, which does not have the risk of infectious disease organisms present as in bone graft bone, but has the same fusion rates as donor bone. And then these can be supplemented with cages or biologic fusion devices such as bone morphogenic protein or VTOS. Patients who often have trouble with fusing the anterior cervical fusion after a discectomy include smokers, diabetics, patients who undergo multi-level fusions, including 3- and 4-level fusions, which are much less commonly performed, and patients who have had a failed fusion in the past, and also patients who have had reaction to an allograft donor. In order to assist these patients in their fusion and enhance their outcomes, cervical bone growth stimulators have been utilized. Orthofix is one of the only FDA-approved bone growth stimulators for the cervical spine. Our group is currently participating in a surveillance clinical study for the use of cervical and spinal stimulation post-fusion in high-risk patients, as we've discussed before. The bone growth stimulator utilizes a pulsed electromagnetic field to promote bone growth. In the past, some of these were implanted surgically in the lumbar spine, but this is a non-implantable device that can be removed and placed on a patient at home. Features of the Orthofix include it's safe and effective for these high-risk patients. It's also lightweight and portable. It can be used at home. Cervical stimulation trials have been done in the past and include a randomized prospective controlled multi-center double-blinded trial, and it has shown to increase the probability of fusion success in the high-risk patients. These high-risk patients, to go over them again, include patients who have used allograft as opposed to autograft, smokers and diabetics, and obviously multi-level fusion patients. The amount of time a patient is required to wear the stimulator includes about 4 hours per day in a minimum of 60-minute intervals. We would determine which treatment is complete based on radiographic evidence of healing, usually in a 3 to 6 month time period that is typical. The radiographic fusion outcomes from the prior study showed that an active patient involved in the stimulation, patient who is using the cervical stimulator, shows an 83.6% fusion rate, whereas a placebo patient shows a 70% fusion rate. It's been used in patients who are smokers, and as you can see, there is an increase in the fusion in a smoker of 86% compared to approximately 70% in the placebo. With multi-level fusions, it's approximately 80% as opposed to 65% in the placebos. In a patient who is both a smoker and requires a multi-level fusion, the increase is about 83% compared to 60%. And there's a fairly significant change with a patient over 50 with 81% compared to 56% with placebo. An anterior cervical corpectomy is another operation similar to an anterior cervical discectomy that would require removal of an entire vertebral body as well as the disc space above and below. Reasons for this would be traumatic injuries and cervical spine fractures, treatment of cancers involving the bone with cervical spinal cord compression, and multi-level cervical spinal stenosis, where an isolated or multi-level disc operation alone would not suffice in decompressing the patient's cervical spinal cord adequately. The way a corpectomy is performed, a trough is usually drilled where the vertebral body was in order to drill this away. We would also remove the posterior longitudinal ligament away from the anterior portion of the dura to decompress the cervical spine. It's usually about 15 or 16 millimeters in width, but oftentimes ultrasound is utilized to make sure that the cervical spinal cord is adequately decompressed. And after the corpectomy is performed, a bone graft or plastic cage can be placed where the vertebral body used to be and have this fused and plated to the level above and below. An MRI scan that shows multi-level cervical spondylitic disease and cervical spinal cord compression is seen here, and you can see that most of the stenosis takes place in the anterior portion of the cervical spinal cord, And that's where an anterior approach with a corpectomy or an anterior cervical discectomy would be best utilized to treat this patient's cervical spinal stenosis. To perform an anterior cervical corpectomy, the same incision is utilized with an anterior cervical discectomy. The difference is that the incision could be a transverse incision as shown here, it could be a longer incision. You can see the area of diseased bone is present with the vertebral disc above and below. We would still remove the vertebral discs above and below to show where the disc and bone interface occurs and be able to locate where to stop the removal of the vertebral. It would show where to stop the dissection of the bone that is involved. And after the disc is removed and the bone is removed as well, the bone graft is implanted and plate is applied as seen before. After the bone graft is inserted, a plate with screws is also utilized again. This procedure can be done independently or can be reinforced with a posterior cervical fusion if necessary. When multi-level cervical spine pathology is present, oftentimes multi-level anterior cervical discectomy infusions or even multi-level corpectomies are not sufficient or safe to provide in certain patients due to their bone health. Another feasible alternative is a cervical laminoplasty. It's often called an open door laminoplasty, and the way this is done is drilling a groove on one side of the lamina, as seen on the green line to your right. And on the left side, you can drill all the way through the lamina on this region. After the removal of the spinous processes, you can see it cracks the lamina open to give more room for the cervical spinal canal. This would allow for relief of the cervical stenosis that is present. Where the bone and open door laminoplasty occurred, bone grafts can be inserted, and sometimes these are even plated as well to provide stability. So as you can see, this is a feasible alternative to a patient who may not have the bone quality for an anterior approach, but may be better served through multi-level stenosis with a cervical laminoplasty or posterior approach. For pathology that occurs posteriorly or in the back of the neck, a laminectomy is an often performed procedure. A laminectomy or laminotomy or foraminotomy can use to treat an isolated disc herniation at a single level. Can also treat cervical spondylitic changes and even anterior bony osteophytes and stenosis from a posterior approach if more than one segment needs to be addressed surgically. A laminectomy would include removal of the lamina and spinous processes to relieve the pressure on both the cervical spinal cord and the spinal nerves. The spinal nerves would be decompressed by performing a procedure called a foraminotomy, or opening up the neuroforamen where the nerve root comes out. Oftentimes, this surgery is done to improve hand function and improve numbness or weakness that may be present. In cervical myelopathy patients, surgery would be also utilized to prevent a worsening of their current situation and prevent progression of their cervical spinal cord damage that may have already occurred. A laminectomy is the roof or the dorsal portion of the cervical spine that is deeper than the spinous process, which is the palpable masses that you can usually feel on the back of someone's neck. In addition to anterior cervical discectomy and fusion, newer technologies including anterior cervical disc arthroplasty or disc replacements have been studied recently. Dr. Joel Pickett was the first neurosurgeon in Alabama to implant a prestige cervical disc in 2003. We're currently involved in 7-year outcomes for this study. It's indicated for intractable radiculopathy or cervical myelopathy with nerve root or spinal cord compression and a neurologic deficit. As seen here, the prestige cervical disc on the left is a way to maintain and preserve motion at the level of involvement of the cervical spinal pathology. With the cervical spinal fusion, obviously the level involved would be fused solid and immobile. The advantages of a disc replacement and the reason that this technology has come about would be to preserve motion at the segment involved. This would hopefully decrease the amount of adjacent level stenosis or degenerative change that may be accelerated by fusing a level in the cervical spinal canal. The disadvantages of this prestige disc or any other disc arthroplasty, both in the cervical and lumbar spine, as it does not absorb axial loading, which is the main function of a cervical or lumbar disc. It's not suitable for collapsed disc or severe cervical spondylitic disease, and currently no trial has shown superiority to the cervical fusion data that is currently present. And as you may remember, the anterior cervical discectomy and fusion has a success rate of around 90%. When treating cervical myelopathy, there are different approaches that can be utilized. Most neurosurgeons would review an MRI scan and determine whether or not the pathology present most commonly is anterior to the cervical spinal cord or posterior to the cervical spinal cord. An anterior cervical spinal approach would be best utilized with a corpectomy, and a way to treat a patient with more posterior pathology may be through a cervical laminoplasty. As you can see in this video, the cervical fusion causes stability of this level without motion, whereas the prestige cervical disc and artificial disc replacement allows for motion at this area. What is not seen, and one of the disadvantages to disc replacement, is the fact that it does not provide axial cushioning, which is the major role of the disc in the normal, non-involved cervical spine. So in summary, neck pain is a commonly seen condition in primary and specialty care. Some of these most common cervical conditions include cervical disc herniations, stenosis, spondylosis, and general neck strains. The majority of neck injuries and conditions can be treated conservatively with therapy and other modalities. When surgical intervention is required, the most common minimally invasive treatments include anterior cervical discectomy and fusion, cervical corpectomies, laminectomies, and laminoplasties. Many emerging technologies are available to assist in the healing of patients, such as cervical bone stimulators. And to receive your CME from Huntsville Hospital Corporate University, please complete the evaluation form and return it to Corporate University to receive your certificate by mail. Thank you for your time, and please visit our website at spineandneuro.com.